Kemi Olawaye Damson, a Ghanaian medical student studying in Canada, had just delivered a long-hoped-for healthy baby girl. But things took a turn for the worse almost immediately after. She began experiencing chest pain and then developed shortness of breath and progressive weakness of the whole body. Apart from a fast heart rate attributed to her medications, all her routine tests were normal. But as she got weaker, she developed marked difficulty with breathing, chewing, speaking, and coughing. She was rushed to the emergency room and then admitted to the intensive care unit of the Royal University Hospital, Saskatoon, where she was initially ventilated by intubation and then later via a tracheostomy. A neurologist examined her and concluded that she was in myasthenic crisis. Olawaye Damson narrated her story in her memoir titled Living with Myasthenia Gravis. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast. In this episode, we will start an exploration of one of the most clearly defined neurological disorders, and that is myasthenia gravis. Olawaye Damson recollected that she had always been constantly tired. She also recalled having previous episodes of progressive weakness and double vision dating back to her boarding school days, which often required her to be admitted to hospital. On two previous occasions during her medical school training, she had experienced difficulty speaking as well as swallowing, and she had struggled with a persistent hypernasal speech. Myasthenia gravis is a debilitating neurological disorder that presents with fatigable weakness. In their book titled Coping with Myasthenia Gravis, Aziz Sheibani and colleagues traced the history of myasthenia gravis to its roots. They noted that the first description was of an influential 17th century Native American chief known as Opechancanoughf. I hope I got that right. They wrote that Opechancanoughf had developed muscle weakness that prevented him from walking but could be alleviated by rest. Typical and classical fatigable weakness. And they said his eyelids were so heavy that he could not see unless they were lifted up by his attendants. Sheibani and colleagues also noted that Thomas Willis, the father of neurology, had described a case in 1672 of a woman who had fatigable weakness and who Willis said temporarily lost her power of speech and became mute as a fish. Myasthenia gravis is caused by impaired communication between the nerves and the muscles where they meet, and this is called the neuromuscular junction. In 1921, the German researcher Otto Lowy had demonstrated that the communication at this critical intersection is chemical and not, as previously thought, electrical. Here, the nerves release acetylcholine, which travels across a small gap to latch onto its receptor on the surface of the muscle. Acetylcholine can be seen as the tonic that prompts muscles to act. To ensure that acetylcholine does not continuously goad the muscles to contract ceaselessly, an enzyme called acetylcholine esterase is in constant patrol in the neuromuscular junction. And like any good patrolman, the enzyme acetylcholine esterase steps in and rapidly breaks down acetylcholine once it has completed its tour of duty. But in myasthenia gravis, the neuromuscular junction is plunged into turmoil by antibodies which bind to the acetylcholine receptors, making it difficult for acetylcholine to bind to the muscle and to move the muscle. And in a double whammy of sorts, the patrolling acetylcholine esterase enzyme, unaware of what is going on at the receptor, mindlessly continues to carry on mopping up acetylcholine, completely oblivious of the fact that acetylcholine has not successfully completed its mission. So, where are these vindictive acetylcholine receptor or AChR antibodies coming from? In contrast to the horrendous damage they cause, the organ that produces the antibodies is an insignificant, puny structure in the chest called the thymus gland. When the thymus spawns these antibodies, they carefully select their initial targets, picking on the smallest and weakest muscles of the body first, almost as if they are practicing and honing their skills for the larger muscles. And the smallest muscles are those that control the eyelids and the eyeballs. And in this case, the clinical picture that results is called ocular myasthenia gravis, and this manifests mainly with droopy eyelids or ptosis. This droopiness is often partial, the eye is not usually completely shut, and it may just involve one eyelid, but more often both. The droopiness typically improves with rest, after sleeping, and if an ice pack is placed on them. This is called the ice pack test. It may also improve with forceful eye closure. When the eyelids are not evidently drooped on examination, they can be easily fatigued and induced to droop when the subject looks upwards for 30 seconds or more. The other major symptom of ocular myasthenia gravis is double vision or diplopia, and this is also transient and induced by fatigue. A vivid illustration of ocular myasthenia gravis is depicted in the illness memoir written by Quentin Taylor Garcia titled The Last Sunset, Journey with Myasthenia Gravis. Taylor Garcia depicted the case of 30-year-old James, saying that the first sign that something was amiss came subtly, as these things often do, in the form of a persistent heaviness of James's eyelids. James's vision then started becoming double, blurring the world into a disorienting duality. He therefore found himself blinking furiously to clear his sight, only for the images to merge for a moment before splitting apart again. The impact of this on James's driving was most worrying. Taylor Garcia wrote that driving once an automatic task became dangerous. For example, he said the tail lights of cars ahead stretched into long, glowing trails at night, and during the day, road signs duplicated, their messages garbled by his unreliable sight. Double vision also affected him when he was coding, his passion and livelihood, transforming the once enjoyable task into a strenuous exercise with lines blurring and commands jumbling. When the thymus can generate a horde of antibodies, their numbers embolden them to now go for the larger muscles of the body, having already practiced on the smaller ones. And the clinical picture that results in this case is called generalized myasthenia gravis. As in the case of James, generalized myasthenia may follow ocular myasthenia gravis. Quentin Garcia wrote that James subsequently began to have trouble speaking. His voice would weaken to a whisper after long conversations, and sometimes he slurred his words as if his tongue were rebelling against him. He added that chewing became an effort, and he found himself favoring softer foods, those that required less bottles to consume. Apart from difficulty with chewing, swallowing, and speaking, this severe form of myasthenia gravis can present with extreme symptoms. These include difficulty closing the mouth, weakness of the neck and limb muscles, a nasal voice, and nasal regurgitation. And in the most extreme cases, as happened to Olawaye Damson, the disease may present in myasthenic crisis. And this is when breathing is seriously compromised. A distinctive feature of myasthenia gravis is the number of factors that can trigger it off or push a patient into crisis. This is vividly illustrated with the illness story of Howard Carras, as he narrated in his book Permanent Detour. Carras first developed difficulty walking and unexplained falls, and he found it difficult to get back on his feet after falling. This was soon followed by difficulty getting into bed, turning over in bed, buckling belts, and even buttoning his shirts. He then developed shortness of breath on walking short distances, associated with intermittent inability to talk, and eventually he needed to gulp for air. He was admitted to the intensive care unit after he became incoherent, turned blue, and drifted in and out of consciousness. He was treated for pneumonia, but after the second dose of antibiotic he was prescribed, something called tequine, he went into respiratory failure again. It was much later that he said, "I found out tequine was in a medication family called fluoroquinolones, and as such it was not recommended to be given to a person with myasthenia gravis." Apart from fluoroquinolones, other drugs can trigger myasthenia gravis, and patients with this condition need to avoid them, or they need to be used with extreme caution. These include ampicillin, clindamycin, erythromycin, oxytetracycline, some monoclonal antibodies, interferon, chloroquine, and quinine. There are also non-drug triggers such as menses, pregnancy, postpartum, infections, hypothyroidism, hypokalemia or low potassium, surgery, trauma, in vitro fertilization, and vaccinations for HPV, HBV, and even COVID-19. When she was tested for the antibody responsible for myasthenia gravis, Olawale Damson was negative for the anti-acetylcholine receptor or AChR antibodies. Okay, I admit it, I have oversimplified things so far. Not all cases of myasthenia gravis are caused by antibodies to the acetylcholine receptor. In Olawale Damson's case, she turned out to have another antibody called anti-musk antibody, and we spell musk in capital letters. This antibody accounts for 30 to 50% of people with myasthenia gravis who do not have anti-acetylcholine receptor antibodies. Anti-musk myasthenia gravis also has a somewhat different modus operandi. It typically presents with marked weakness and wasting of the muscles of the face, the tongue, and of swallowing. It also generally manifests with a more severe form of myasthenia gravis, tending to lead to myasthenic crisis more frequently than the more common anti-acetylcholine receptor myasthenia gravis. And in a demonstration of its wily military tactics, myasthenia gravis may rarely present with both antibodies. This is called double positive myasthenia gravis, and it expectedly carries a worse prognosis than single antibody myasthenia. And to complicate things, another antibody has cashed in on the simple and effective strategy that musk and acetylcholine receptor antibodies do, and this is anti-LPR4. This antibody is present in 9 to 90% of double seronegative patients, and it may combine forces with these other antibodies, giving rise to double or even triple positive myasthenia gravis. Fortunately, as anti-LPR4 antibodies lead to a mild form of myasthenia gravis, it usually just presents as ocular myasthenia. Even after all the known antibodies for myasthenia gravis have been checked for, there is a chunk of people with myasthenia who have no antibodies detectable in their system. The investigation of myasthenia gravis includes performing a chest CT scan or an MRI scan to look for an enlargement called hyperplasia of the thymus gland, or even to look for a tumor in the thymus called a thymoma. Surprisingly, and perhaps mercifully, the scan is often normal, but not for Mereti Taipana Howe, who narrated her story in the book titled Taming the MG Dragon. Surprisingly, she had a CT scan of her chest only after she developed chest pain whilst already on treatment for myasthenia gravis. And gravely enough, the scan showed that she had a stage 2 malignant thymoma. She initially had radiotherapy for this, during which her illness unfortunately flared up into what she called the MG Dragon crisis. She was admitted to the intensive care unit where she was intubated and ventilated for 2 whole months. Another confirmatory test for myasthenia gravis is an electromyogram or an EMG. This is an electrical test of the functions of the nerves and muscles. This test for fatigability of the muscles using repetitive nerve stimulation or RNS, and it also looks for what is called jitter using a modality called single fiber EMG. Single fiber EMG is considered the most sensitive diagnostic test for myasthenia gravis. We are now well placed to explore the treatment of myasthenia, and our point of departure for this is the summer of 1924, when a medical student called Harriet Edgeworth developed intermittent double vision followed by right leg weakness. A neurologist diagnosed her with myasthenia gravis, and by 1927 she was struggling to chew, swallow, and breathe. Attempting to treat incidental menstrual cramps in 1927, she herself took some over-the-counter ephedrine, which incidentally dramatically improved her symptoms. She published her own case report in the Journal of the American Medical Association, first in 1930 and then in 1933, reporting that she had sustained improvement with regular use of ephedrine. This was the first time an effective treatment was documented for myasthenia gravis, although the discovery was serendipitous and Edgeworth didn't know why ephedrine helped her symptoms. This brings us to Dr. Mary Broadfoot Walker, who knew exactly what she was doing when she tried physostigmine on her patient with myasthenia gravis. Physostigmine is an alkaloid with a similar mode of action as ephedrine. Walker was described as a quiet, unassuming assistant medical officer at Alfege's hospital in Greenwich, and this description was by Frances Ashcroft in her book titled The Spark of Life. The reason that Walker considered using physostigmine is because this is the antidote for curare poisoning, a condition that she had observed had similar clinical features to myasthenia gravis. Therefore, in 1934, Walker administered oral physostigmine to Dorothy Codling, a 34-year-old chambermaid who had had myasthenia gravis for 6 years at that time. Previously so weak she was unable to lift a cup and confined to bed, physostigmine made Dorothy able to walk shortly after the administration. It is no wonder, therefore, that this phenomenal event has become known as the miracle of Alfege's. Both ephedrine and physostigmine work by blocking the effect of acetylcholine esterase, the enzyme that breaks down acetylcholine at the neuromuscular junction. In this way, they boost the levels of acetylcholine, which enables acetylcholine to compete favorably with the antibodies so that it can access the receptor and at least get the muscles to move. There is, however, a twist in the priority for using cholinesterase inhibitors in the treatment of myasthenia gravis. It emerged that 2 years before Walker, another gentleman called Lazar Remen, a German physician, had used a different agent, neostigmine, with the same effect. That is the history of science. Some are unfortunately forgotten. Let us now explore the history of physostigmine a bit further, a story that is as fascinating as the miracle of Alfege's. According to Ashcroft, physostigmine is the active ingredient of the Calabar bean, known with its Latin name Physostigma venenosum, but it also has a Nigerian name Esere, from which its alternative name Eserine was derived. Ashcroft wrote that the Calabar bean has been used for centuries in tribal rituals to determine if a person is guilty of witchcraft or possessed by evil spirits. She explained that the accused is forced to swallow the chocolate brown bean and is deemed guilty if they die, but innocent if they vomit up the beans. She, however, remarked that the outcome is dictated by the amount of poison the victim swallowed, a fact that enables those in power to manipulate the dose administered to achieve the verdict they desire. The Calabar bean also has played a more recent forensic role when it was used in the gruesome murder of a young boy whose headless body and limbless torso were found floating in the Thames in September 2001. Ashcroft said that the analysis of his gut contents revealed the remains of the Calabar bean plant, which both helped identify the country that the child came from and led detectives to speculate that he was poisoned in a black magic ritual before he was dismembered. Having gone through ephedrine, physostigmine, and neostigmine, neurologists finally settled on pyridostigmine as their preferred acetylcholine esterase treatment for myasthenia gravis. This is because it has the advantage of a longer time in the body before its effects wear off. It may, however, also produce such side effects as cramps, diarrhea, sweating, excessive secretions, both respiratory and gastrointestinal, as well as a slow pulse rate, fasciculations or muscle twitching, and an overactive bladder. For this reason, pyridostigmine is frequently given along with propanthelin to counter these side effects. Because pyridostigmine is only a symptomatic treatment, it does not address the problem of the excessive antibodies responsible for myasthenia gravis. Some people with mild, usually ocular myasthenia gravis, can get by with just pyridostigmine, but those with generalized and severe disease often need the addition of an immunosuppressant medication to control their disease. This is reflected in the case of obstetrician Ronald Henderson, who developed myasthenia gravis in his mid-50s. Narrating his story in his memoir titled Attacking Myasthenia Gravis, Henderson first presented with transient but recurrent episodes of generalized fatigue, which got worse as the day went by. Typical fatigable weakness. He then developed weakness which first started affecting his speech, saying his voice became periodically weak, thin, often raspy or crackling, seldom capable of enduring or projecting, and at times simply giving way. His subsequent difficulties included problems with lifting anything of any weight, twisting bottle caps, and buttoning shirts. As things escalated, he had difficulty chewing and holding his head up. He saw a neurologist at this stage who diagnosed him with myasthenia gravis after a tensilon test. This is the injection of a short-acting cholinesterase blocker, also called edrophonium. This is a short-acting medication which transiently relieved Henderson of his symptoms and helping to confirm the diagnosis. He was then started on pyridostigmine to good effect, but the response wore off with time. At this stage, he was started on immunosuppressant treatment with prednisolone, which is used usually for a short term, and azathioprine, which is used for long-term immunosuppression. Henderson remarked that these immunosuppressants did play a significant role in helping me get back on the road toward a healthier life. Prednisolone, a steroid, is almost always the first-line immunosuppressant used in myasthenia gravis, but because it has a multitude of side effects, it is usually prescribed along with one of several steroid-sparing immunosuppression treatments, and azathioprine is usually the first to be considered. The other traditional options include methotrexate, mycophenolate, and cyclosporine. More recently, however, more powerful agents have been introduced for refractory cases of myasthenia gravis, and these include rituximab, eculizumab, ravulizumab, efgartigimod, rozanolixizumab, and zilucoplan. They make it difficult even for the specialists to pronounce these drugs. All these treatments are, however, ineffective in the most severe and life-threatening manifestation of myasthenia called myasthenic crisis. This is, as we've seen, when respiration is compromised by the disease. The treatment of myasthenic crisis takes the form of either mopping up the antibodies with intravenous immunoglobulins or washing the antibodies out of the system using plasma exchange. Another treatment of myasthenia gravis is thymectomy, the surgical removal of the thymus gland. This is indicated when there is a thymic tumor, a thymoma, as we have seen. It is also indicated when the thymus is enlarged, called thymic hyperplasia. But it is also done in some cases where there is no tumor or hyperplasia, and this is in patients who are positive for the acetylcholine receptor antibody. And you have to be under the age of 45 for this. The history of thymectomy for myasthenia gravis goes back to 1911 when Ferdinand Saverbrook serendipitously found out that the operation improved myasthenia gravis in a man who had the operation done for a hyperactive thyroid. You wonder why the thymus was taken out. The first thymectomy done deliberately to treat myasthenia gravis was, however, in 1936, and this was done by Alfred Blalock to remove a thymic tumor. Blalock is also famous for initiating surgery for congenital heart diseases. Contrary to the expectation that removing the thymus should cure myasthenia gravis, sadly, this again is not always the case. This is illustrated by the example of C.M. Lewis, as narrated in his memoir titled Living with Myasthenia Gravis. Lewis had a thymectomy after he continued to suffer the symptoms of myasthenia gravis on the conventional treatment with immunosuppressing medications. Unfortunately, even the thymectomy only gave him partial remission from his symptoms. And this is because he has what is called refractory myasthenia gravis. This is a big topic, and to explore it further, I will be speaking to Nicola Silvestri, co-author of the book Recognizing Refractory Myasthenia Gravis, in the next episode of this podcast. Apart from the books I've already cited, I found the following source helpful, and this is by Alison Christie, titled Harriet Edgeworth, A Mysterious Story in the History of Myasthenia Gravis, published in October 2022. If you found this podcast enlightening and even entertaining, why not click on the like button, and why not subscribe to the YouTube, Spotify, or iTunes channels so that you do not miss the next episode of the podcast. Whilst waiting for that, why not check out my book called Surfing the Brain, where I have approached neurology in a down-to-earth way. And if you want the hard facts on myasthenia gravis, you may want to check my neurology database called Neuro Checklist. Thank you very much. Until the next episode.